Very good afternoon, everyone. Welcome all of you to the ninth Wisdom Eve talk organized by the Human Resources Development Unit of the University of Peradeniya. Today, I have the privilege of introducing you the speaker of the day, Dr. V. Sivakumar. Dr. Shiva is a proud product of the Physics Special Degree Program of the Faculty of Science at University of Peradeniya. After joining the Department of Physics as a lecturer, he secured a graduate scholarship from the prestigious Georgia State University, USA, in 1999, from which he obtained his PhD in spectroscopy and biomedical physics. After returning to the Department of Physics, University of Peradeniya, he has served as the head of the Department of Physics, coordinator of the Science Quality Assurance Cell, and the chair of the Faculty Research Committee, and in numerous other positions in the Faculty of Science and at the Postgraduate Institute of Science. Dr. Siva is externally affiliated with our Faculty of Allied Health Sciences and several state universities, including Kelaniya, Sabaragamuwa, Rajarata, and Southeastern, while serving as a program reviewer for over 5 different state universities. His research expertise is in infrared, visible, and ultraviolet spectroscopy, medical dosimetry, radiation shielding, and computational molecular physics. Along the way, Dr. Shiva has received numerous awards for research, including several presidential awards for research, university research excellence awards, numerous faculty research excellence awards, and patents for scientific innovation. Apart from his research, he is famous for his charismatic teaching style and education research, which have earned him several more awards. Without further ado, let me make way to Dr. V. Sivakumar as we unofficially got to know newly appointed professor in biomedical physics. This one. You're talking.
Yep. Okay. Good afternoon. It's always a privilege to be here and talking in one of my favorite area. Before I start, let me thank the committee which is organizing this series of talks, and especially Dr. Kapile for introducing me. And initially, was asking me, about this talk, and we were thinking about how it can be kind of pitched so that people will come to this talk. And then we realized, yeah, we'll go with something with the medical radiation. Then people thought, it would be better something to be there, like seeing inside the body or something that will be more attractive. So that's how we end up with this particular topic about seeing inside the body. And there are three things I would like to cover in this topic. One is the medical imaging, which is about seeing inside the body, and medical radiation itself. What are these radiations medically we use for various purpose? And the last one is about the safety, which is more important as general audience to know about the safety on this. So let's get started. Seeing inside the body or the medical imaging means it's about looking inside the body. And as commonly we know, a practitioner or maybe a medical doctor becomes very famous when he can diagnose something timely than any other process. It's like, you take your car to a mechanic, and if he can't find what the problem in one visit, you think, he's not a good mechanic. So likewise, there are issues in the medical. Not now, but those days. Because we didn't have much facility that time. So if you look at early 1800s, illness was, or finding an illness was kind of a guess or educational guess, because they don't have much of these tools what we have, like ultrasounds or maybe x-rays for us to use to find what the problem inside is. So it's basically the clinical examinations, maybe the blood sample or the urine sample, or symptoms, what the patient says about the illness, or guess. I mean, that's what primarily, I mean, guide the doctor to kind of see or to guess what the problem is. And an important part is without looking inside, there is very unlikely, I mean, you can recognize or maybe identify the condition, why, what the problem is. So you need to see inside. So that make the necessity for medical imaging. So seeing inside the body came, I mean, because the development of science, especially physics and technology, so that we can, without using any invasive methods, we can see what the problem inside is. So what is medical imaging? Medical imaging, something that we say, I mean, a window into the human body or some extension of your vision so that you can see inside. These are non-invasive, means you don't need to cut open and see it. Like, I mean, if there is a problem in the carburetor or something in your car, you have to open the bonnet and, sometimes you remove the radiator to see the AC, or, I mean, there are ways you have to get in. And the problem is, without opening or getting in, how can you see the problem is? So in medical imaging, the definition is it's a process of creating the visual representations of interior structure as well as the function, so that you can use it for clinical purposes and some interventional purposes, or maybe for research you can use it. The whole story of medical imaging started in early 20th century or end of 19th century, somewhere around 1895. And these three, or maybe four, pioneers were the first to kind of come up with these, or at least to find something inside without kind of cutting it open. So the major role played. So these are the well-known physicists. Röntgen is the first in your diagram on the left, and then Henry Becquerel, and then Marie Curie and Pierre Curie. So these are the people who actually, I mean, came up with the radiation and using radiation to kind of find internal structures. Röntgen, while he was working on these cathode rays, he accidentally came up with this ray which can penetrate various structures and materials. And he was the father of diagnostic radiology and radiography in starting in 1895. So that accidental discovery laid the foundation for the field of medical imaging. More than 120, 30 years, we now came up with this. So the first Nobel Prize in physics was given to Röntgen for this discovery of X-rays. Then in 1903, the rest of the three shared the Nobel Prize. Half went to Henry Becquerel and half went to the couple, I mean, the husband and wife, the Curie family. That is for the identification or maybe the invention of radioactivity. Very close. This was 1895, the Röntgen's one, and this is 1896. 1 year, I mean, difference there. So as soon as Röntgen came up with these rays, or maybe identified these rays, these are penetrable and we can see inside. So in 1896, there was his paper, which was translated to English in Nature, and where there was a diagram or maybe a image came up, and that was the first medical image in the history. And that was in 1895, somewhere in December. That was his Bertha, the wife's hand with the registration or maybe the wedding ring. It was taken, and that was the historic and the first internal structure identified about 130 years ago. So what is X-rays? I mean, I don't want to go in more detail because I see, I mean, most of the people are from the science background. It all from the type of radiation or maybe the waves, we call them to be electromagnetic radiation. And if you look at from the left, I mean, the less energy, less frequency ones are the radio and TV waves. Then you have the microwaves used for cell phones, communications, routers, and so on. Then you have the infrared is about the heat radiation. Then you have your visible, which is only one we can, or maybe the one that we can use it to see things and feel. And then comes the ultraviolet, X-rays, and gamma rays. And these about the ultraviolet and part of the ultraviolet are ionizing radiations. We label them that way because they're dangerous. They can do the ionization. Now, under the medical, we don't that much use the UV though, but we'll use the X-rays and gamma rays for various purposes. So under medical radiation, we have these two types, X-rays and gamma rays, used for various purposes. When I say ionizing, what that means is the energy of the photon is high in a way. It can remove an electron from the orbit of the atom and making the atom to become an ion. And if you look at the comparison of this energy, what I'm talking about, if you look at the normal visible light, the visual region, if you take the energy of the light to be somewhere around 3 units, usually it's about 1.8, 1.9 electron volt to about 3 point something. So if I quantify that to be a 3 unit one for the photons, now the X-rays are about 20,000 times more. And don't worry about the kiloelectron volts and the electron volts, but you can compare the units 3 and 60,000. So that much high energy photons are the X-rays and gamma rays. Gamma rays is even more. And they have the ability to remove an electron from the orbits. So that's what we call them to be ionizing radiation. So just to give an idea about how energetic these photons are. So why this X-ray thing is a matter to us? Because it is invisible. You can't see if there is an X-ray passing through this room. You can't identify there is an X-ray going on. You can't feel it because it is not a flash to see the light, or you don't even feel the heat of the X-rays. So you can't feel there's an X-ray going on. So the exposure to these radiations are without your awareness, because if you go and stay there, even the radiographer click the button to expose your radiation, you don't know that it was happened. So that's the dangerous part of the X-rays. So the other serious one is it can ionize the medium. So wherever the X-ray passes through the medium, it can do this ionization part. And doing that, what a big deal. The deal is it can interact with the regular molecules and the our biological systems and the biological molecules, because this is an ion. It's highly reactive and it won't kind of go with the interaction. So that is not good for health in terms of the risk. So the message is not to kind of scare. I want to emphasize this because it doesn't mean X-ray imaging is bad. So don't get that impression about by looking at the X-ray energies. But they are safe when you can use it wisely without going for some unnecessary exposures. That's what the main part of these the talk today. I mean, unnecessary exposures are the problem. Under the medical radiation, it's not only the ionizing radiation comes, it is even non-ionizing radiation also we use in medicine for mainly the diagnostic purposes. For the treatment purpose, we go for the high energy, I mean, the ionizing photons, like high energy photons, X-rays and gammas. So ionizing radiation, we can classify them into diagnostic and therapeutic. The therapeutic means you try to cure it or maybe treat that. Diagnose means you find what the problem is. So get those two terms clearly, because diagnostic means you just want to find out what the problem is. Then, if you can cure it by radiation, then you go to the therapeutic. And the diagnostic and therapeutic, I mean, they won't overlap, because if you look at the purpose, the diagnostic is to detect the disease, what the problem is, right? And the therapeutic purpose, what we use the high energy photons, gammas and all, for treat the patient and treat especially the cancers. Then the radiation dose, the amount of energy imparted on the patients is low, because you just want to find what the problem is that is in the diagnostic. And it is high dose, obviously, for therapeutic ones. Then the purpose is, I mean, find what is inside. So it's about imaging and getting the information. And in the therapeutic, we want to kill the cells which are bad, to be in the system. So it is a destruction there for the cells. Then there are examples. I mean, normal X-rays, CT, PET, and all goes under the diagnostic. And therapeutic ones, I mean, there are many. I just put only two. The external beam therapy, we known as sometimes teletherapy. We use cobalt. It's very old, but we can use the LINAC and so on. The other one is the brachytherapy, where the source of radiation is inside the body. You insert these isotopes and let them radiate, and kill the cancer cells. So that's a separate topic, but just leave it at the moment as it is. So, yeah, these are the commonly used diagnostic medical imaging techniques overall. I may not cover all, but just to classify in terms of X-ray related images, projection radiography, which is normally what we take it in the X-ray labs and all. 2D images, those are plain images. That is the very common one. And the CT, which is high dose, but that is the second in the line. Then mammography is another X-ray related one, which is about the image in the breast, specially designed devices with low energy X-rays. Then the other one is the fluoroscopy. There are various fluoroscopies are there. Angiography is one. I mean, this is compared to others. Now, if you take a X-ray and you can take that to next day or maybe after a week to show that to the doctor to find the problem, same as maybe the CT and mammo. But fluoroscopy mainly used for interventional procedures where it's on while the patient is there. For example, if you have a broken bone or something, I mean, they will keep it onto this. There are various devices. They keep it your the hand or whatever on the screen, where the X-ray comes out, and they look at the broken part and they try to fix it something, or using a stent. I mean, inserting a stent to the right place, or finding where the block in the vessels. I mean, so they use a dye and they just let that dye to pass through and they just look at it. So these are interventional procedures commonly used in fluoroscopies. And ultrasound imaging, I put a different color for a purpose. It is about the sound waves we use for imaging. There is no ionizing properties at all. These are like normal sound waves. Whatever you hear, if it is safe, then ultrasound is also safe. Nuclear, it's a bit high in photon energies, and there are various imaging techniques we use. Here in Peradeniya, our nuclear medicine unit, and I see people from nuclear medicine unit here, they have a planar gamma camera, they have a SPECT and single photon emission computer tomography, and we don't have a PET, but these all comes under the imaging modalities under the nuclear medicine. Then MRI, the magnetic resonance imaging, is another imaging modality which is safe in the sense it does not involve with the ionizing radiation. So people have a misunderstanding that MRI is something very dangerous to be there because they're worried about this magnetic field. And we hear about the accidents that because of the magnetic field, not because of the high energy photons. Now, yeah, let's move on. If you look at the modalities, different modalities, now I'll take one example to explain. I mean, each medical imaging modality is based on separate science and different technology. For example, if you compare the X-ray imaging versus ultrasound imaging, very commonly used one, they have two different science. In ultrasound, we use the sound wave. Now, sound wave is a longitudinal and it's not harmful. And if you can be in front of the speaker and listen to music or in the musical events, if you're very close to the speaker, I don't think you'll get any effect unless it is too loud and damage your hearing part. But other than that, there is nothing ionized in them. But on the other hand, the X-rays are high energy, and normally it goes from 10 to 115 kilo electron volt. These are the maximum in the spectrum. And in the ultrasound, we wait for the echo to come and tell us what the problem inside is. Whereas in the X-rays, it is about the X-ray transmit through your body and get to the detector on the other side. So along that line, this X-ray may be modified or maybe lose the energy, and it may be absorbed sometimes by the photoelectric absorptions and all. So even an absorption or losing a photon, there is a message. I mean, about the internal structure as well as the whatever the problem we're looking for. So that is what is transmitted through the body to kind of tell us what we're looking for. And acoustic impedance is the key for ultrasound images and all, because don't take it as it is impedance, which is the density and the speed of the sound dependent quantity. Then the attenuation, whether it is photoelectrically absorbed or maybe a scattering like Compton scatterings and all that get into the in the medium about the X-rays. Now, diagnostic part in the ultrasound depends on the frequency what you're using. Now, all these ultrasound images are in the megahertz region. And I hope you have some idea about this frequency because our hearing ability or the audible frequency is only about 20 hertz to 20,000 hertz. But we are talking about something in the megahertz. And in the diagnosis, again, I mean, if somebody want to see the bladder, for example, or maybe the uterus or something in the abdominal scan, they can't go for high frequency ultrasounds because that attenuates very quickly and you can't go into more deeper to see the internal structures if you use, let's say, a 10 hertz 10 megahertz frequency. Normally in the abdominal and chest and so on, they go from 2 megahertz to roughly about 5 or maybe 6 megahertz. But if you want to see the ophthalmological measurements in the cataract, for example, if you want to measure the biometrics, some measurements there, they can go for 10 to 15 megahertz because the attenuation is less, no need to penetrate more. And so it depends on the frequency what we use. So it's the technical person or even the doctor to decide, I mean, what kind of frequency and the transducer to be selected. On the other hand, in the diagnosis of using the X-rays, again, that depends on the energy of the photons. If somebody is going to kind of image maybe a fracture in the hand to see what where it is and how it looks, maybe about 60 would be the maximum keV photons in the spectrum. But on the other hand, if somebody is going for a chest X-ray, it's about 120 or maybe 150, depending on the size of the patient. The radiographer can adjust the kVp values. A simple example to talk about these echoes, because I just want to take one and give you the taste of, So this is a cyst in the breast, and you can see the area. That's the area. It's completely dark, means there is no reflecting sites inside the cyst. Cyst is a fluid filling. But if it is a breast mass, for example, there is something solidified or maybe a solid layers there, then you have echo sites or reflecting surfaces there in the breast. So there is a big difference between looking at a cyst versus maybe a breast mass or any area where you see no reflections because it's a uniform fluid and there's no reflection sites. So just to give a idea about one simple example, but it's very complicated, and the way we use, there are different modes in ultrasounds. It's not just simply as this, but just to give a idea of this, looking at something internally and deciding on what it could be. There's no perfect window in medical imaging. What that means is you can't use a single modality to cover everything that you want. What you see on the left-hand side is an X-ray or a mammogram. It's a image of a breast with some mass, a growth in there, could be malignant. And what you see on the right side is an ultrasound image of a fetus inside the womb. Now, can we use an X-ray for the same to look at the development of the fetus? No, we can't. The reason is it's an ionizing radiation. You don't want to expose the fetus with that energy, which is very dangerous, and it can create more problem. So the only way to at least 3 times or 5 times or 7 times to look at the development throughout the pregnancy, I mean, ultrasound is very safe. If you can listen to a music, means you can scan through ultrasound. The problem with why then you have to use an ultrasound rather than play a music and look at the baby inside, we can't do that. And I used to ask this in my lectures. The reason is the normal the audible sound what we have is very low in lambda, the wavelength. But if you want to see something in a millimeter size or maybe a fraction of millimeters, then you have to have a very small lambda, the wavelength, to see that. So only way you can make the lambda to be small going for high frequencies, because you know the relation between the speed and the frequency and the velocity. And velocity is basically fixed in biological system about 1500 meter per second. So if the v is fixed, then you adjust with the frequency so that you can get a small wavelength and you can get a high resolution to see something. The resolution is extremely important in medical imaging. We should not miss anything diagnostically because that's end up in a disaster, and there are many examples. To avoid that, the resolution of your imaging has to be extremely good. So ultrasound and there are images, I mean, where you can fuse them or you can kind of overlay them one with the other, and then you can exactly pinpoint where the problem is. Now, the diagram what you're seeing or the image is a combination of a CT and a PET scan. PET scan is a very expensive one. I think we have only 3 in Sri Lanka because you need on-site these radiopharmaceuticals produced. Otherwise, you can't. The first PET came to Sri Lanka is 2007. I can mention the name. The RCD hospitals bought the first one. Then in somewhere around 2000, I don't know, 17 or 16, only the Maharama got one through a lot of donations. There are many people helped. I mean, that was a wonderful project to kind of get the PET scan. Then now we have one in the National Hospital as well in Colombo. The problem with the PET is you have to have a radiopharmaceutical, especially the FDG, that fluorodioxyglucose should be there to kind of use it. In the fluorodioxyglucose, I mean FDG, we use a fluorine 18 isotope, which has only a lifetime or half-life of 2 hours. So if you produce an FDG somewhere, let's say you produce, I mean, you're taking it from India to Sri Lanka, 2 hours is gone in the while bringing it and injecting that into the patient. So what we normally did was when they got these radiopharmaceutical from India, they went for very high radioactivity of these radio samples, which is very expensive, and then they had to transfer it here. About 80-85% of the activity is gone by the time it reaches the PET scan machine, and then you had to insert and find out. Roughly, I think it was a cost of about 2 lakhs for a scan in a private place. I mean, to get a PET scan done. But the best part, if you look at the diagram, that is, oh, I can see that. Yeah, the hotspot or maybe the nucleus area. I'm sorry. The main area where you have the isotopes are concentrated is in this area. I mean, where you see is a bright kind of a spot. That's where all these FDGs were kind of accumulated where the cancer is. So if you take this only the PET scan and look at the location of the cancer cells, you may not get a very accurate kind of location. So what they do is they send, they have the CT and the PET together. So while this patient is taking the PET, they will send through the CT as well. So you have 2 images now. Then they fuse these two to find out exactly where the cancer is so that they can plan their radiation treatment accurately to kind of get the cancer cells. Okay, I think we spend more time on that. Anyway, it's worth. Yeah, now we need this. I was thinking twice to have this in the slide now. How this happened? I mean, in a normal setup, if you look at the arrangement in a medical laboratory or maybe in a imaging or maybe a radiology department, the imaging system looks like this. So there is a patient who's supposed to be imaged. That's on the left-hand side you're seeing. Then there is an imaging system. It may be a CT, it may be ultrasound, it may be a PET, whatever the imaging system is. Then there are certain characters that we need to improve and make it optimum. Then you get an image, and there are 2 people supposed to kind of work on this to kind of tell what the problem is. One, the person who is operating it, we call him to be the radiographer usually. And he select these parameters in such a way he get a better image so the doctor can interpret what the problem is. So the person who is observer there is a radiologist, MBBS, with the specialized in the radiology, and he or she is the person who is going to interpret what the problem is. So this person, operator, please make a note on him. I mean, we will be talking about him more because he's the main man in our radiation protections and the safety and whatever we talk about. So when you have a patient, if there is something abnormal in a place, you see the red color kind of a patch in the brain, that could be the problem, and we want to kind of get that out to make it as a image so that people can identify it, right? So along that line, you have various factors there. Artifacts comes in, the way you position the patient and so on. Blurring, which is out of focus, can be there. Sharpness is gone sometimes. Contrast has to be optimum, not the maximum. It should be optimum, and we have to reduce the noise, we have to avoid the distortions and so on. So there are various factors we cover usually in the image character kind of a one. There are major five, and I'll give you an example on the contrast just to have an idea. Now, the contrast means a clear difference you need between the background and the one that you're looking at. So you need to have a clear difference. So if you look at this kind of a vision test, you can look at the letters which have different contrasts compared to the background. Now, A is high in contrast along the line B, C, D, and so on. And I hope you can see the letter F with that contrast, which I barely see it in my screen here. Can you all see the letter H on the screen? The letter H, I can see from that screen. I can't see it from here. How many of you can see the letter I? Don't worry, there's no I. Only up to H I we have. So what that tells us is we need the details. We need to see things, inside the body so that we can. So people miss sometimes. If somebody missed the H, imagine, we're always talking about this. And when I was preparing the slide, I was almost emotional when I hear about Professor BSB, because he was diagnosed, with this cancer. But he went for a kind of a test in November somewhere, but he was diagnosed with the level 4 in February. So for mom, getting into fourth level is impossible. So we missed something, and that's what he thinks. And when we had a discussion, so diagnosing is extremely important part. And if you missed it, you missed it. And you think I'm fine, there's no issue to me, and I can have my normal life, and I can eat anything, or maybe to change the lifestyle. But after maybe many months, sometimes you will be diagnosed with the different levels, or maybe which may be kind of treated or maybe cured. So diagnostic part is extremely important. That's what we all struggle to kind of give the right information, or maybe the correct information at the right time to the physician so that he can kind of come up with what the solution is. So there should be a physical contrast inside the body so that we can recognize in the image. That is extremely important. So imagine this is some kind of a abnormal growth inside the brain, which should have to have some kind of a different contrast physically so that we can see that in the image. So the physical contrast is related to your image contrast. Now this varies for different modalities. For the X-ray to be detected, through X-ray images, we have to have some physical contrast. But if it is ultrasound, it's different, and so on. So the contrast is extremely important to kind of identify. And there's another image. This is my hand. I broke my hand, I don't know, 3 years ago, and they were inserted these pins inside, and it has a totally different density. And you can see even in the background of the bone, you can see the pin. So what that tells is, the contrast and the physical properties of whatever you have inside should be clear enough to see as a image contrast at the end. Okay. So we'll move to another part of this talk. I'll quickly go through this. We're almost there. In normal sense, if you want to take a photograph, and you have been, to the studios and all, I don't know. Now it's not that popular, but those days, the family visits the studio time to time to take the family photographs, and they have a reason for that. And if you go there, they will have all kind of lights to kind of set to you so that they can get all the beauty from you to kind of to the image, right? All the details, they can get it. So if that's the case for a photograph, getting more light to the object so that you can see the image clearly, how about in the medical imaging? Yeah, that's true in the medical imaging as well, where you have to have a lot of radiation or high amount of radiation, or we call high dose of radiation, so that you can get the quality of the image much better. The doctor will be very happy. And is it okay to go for that? Do you want to make the physician or the doctor happy more than on the expenses of imparting more radiation onto the patient? So it is always the ethics in medical imaging and in the radiography. So you have to optimize, in the sense, not the maximum, not the minimum, and you have to optimize both, in the sense you have to give the amount of radiation needed so that you don't compromise the diagnostic value, or maybe the amount, or maybe whatever you're going to get it, that we can't compromise. So the medical optimization is kind of making sure that the patient is safe, not the patient alone, even the operator, while clinically we get a useful information. I mean, the diagnostic part, without compromising that, we have to minimize the radiation. There is a principle known as the ALARA principle, which is stands for the as low as reasonably achievable. Means you don't want to kind of give him a kind of a image that he can hang on the front living area, so that he'll be happy. This was taken in my A levels. This when I was graduate. No, it's not like that. I mean, so it is not something that we need to the clear and accurate and very nice image for us to keep it for us as a kind of souvenir. No, this is something that the doctor want to find what the problem is. That's the whole purpose of taking an image. So can we go for as low as achievable, something that with the low radiation, obviously without compromising the diagnostic quality? This ALARA principle is very famous in radiation protection. I mean, there are not just the low radiation dose, the time that you spend on the radiation facility, or maybe in the radioisotopes, the distance that you're maintaining, and the shielding also come into that, which is a different area, which I just skip and move on to the another area about the organ sensitivity. Now, in human, all the organs are not equally sensitive, because the way the cells replicate, the way the cells have a particular job to do in that particular organ, and so because of that, the sensitivity is not the same. According to ICRP, they have classified different organs into different sensitivity. Now, if you look at this list, the high sensitivity organs are there. So the thyroid, especially, and stomach, colon together, lungs and breast, and bone marrow. Obviously, it is one of the sensitive organs for radiation, which we have to, I mean, protect it by shielding whatever the way we can. There are moderate and there are less sensitive organs, and we thought the brain is something very important. We have to protect it, but it's very less sensitive because we have a skull to protect us. So brain is not a very sensitive organ for the radiation. Liver, bladder are in the moderate level. This is the so the ICRP, which is known as the International Commission for Radiological Protection. It's an UN-based organization. The other people come up with these weighting factors for different organs, and I have three different tables. The latest one came in 2027. ICRP publication 103. That was the latest we have, and I hope we'll get something soon, near soon. According to that 2007 recommendations, the high sensitive ones are given weighting factor of 0.12, and then gonads, which I didn't mention that in the list there, which is in between the medium and the high. Gonads are the reproductive organs, where the ovary and testes comes in. So initially, if you look at the 1999 publication or the recommendation, the gonads, the reproductive organs, were there in 0.12 as sensitive organs, but they scale it down. Now you may be wondering, I mean, who decided that? I mean, to move that thing down and move. Breast was, I mean, in the 1991 was in the 0.4 case, but it was moved up now. The reason is they wait for the accidents and all these radioactive, I mean, the radiation related accidents, the meltdown of Chernobyl in 86, I suppose, and then Fukushima in 2010. So they need samples. I mean, they need stories, and you can't get people for volunteer RAs to be as a subject to kind of study this. So it's not that easy. So it varies, and I'm wonder. I mean, whatever the publication comes after this, it may have maybe slightly different weighting factors. So, what is the important consideration here is the repeated exposures. That's what I worry more, because sometimes the problem of the person, the operator person, I ask you to kind of focus him. Maybe his fault, or maybe the patient's fault, the positions. Sometimes you have to repeat sometimes certain procedures, which is extremely bad. So repeating a chest X-ray means you are, double dosed, and that is extremely bad. So the repeating exposures are the very risky parts, and sensitivity varies with the age and the biological conditions. Kids or the pediatric patients are really vulnerable for radiation. So I have a slide for dedicated for that, because why children are more, I mean, to be protected more, because many reasons. One of the reasons is the cells are replicating in a very exponential form. So when you expose a kid at that stage, less than maybe 15 or 18 years old, is extremely bad, and there will be a cancer risk, I mean, getting in later on. And they have a long life, or they have um, a time, I mean, more than adult. Like, for example, if somebody is exposed at the age of 15 or 10, these cancers, especially the radiation induced cancers, especially the blood based ones, they take at least about 5 to 10 or maybe more years to get a symptom. So there is a time known as the latent period for these cancer development. And if a person is exposed at the age of 80 for a high dose, and if something is developing, I mean, 20 years is in 100. I mean, there's anywhere to go. But imagine a kid at the age of 10 and exposed to radiation and developing. We have enough evidence at exposing at the small ages and developing a blood related cancer. There are a lot of evidence now, which is extremely bad. So that is a extremely important message. I just want to make it here. There are a few studies. I'll go through that and finish this. This is a journal article came last year, April, almost 1 year ago, in the Journal of Medical Association of American Medical Association, one of the top class journal. The impact factor is more than 20, where they found, I mean, projected lifetime cancer risk from computer tomography imaging, whatever the way that they are producing it. So what the article says is they studied about 93 million CTs. So this many number of images they have taken, and accordingly, they have these number of 4% of children and 95% adults and so on. The important part, if we continue this rate of CTs, this is not in Sri Lanka though, don't worry about it. It's in US. And US is very famous for, I mean, getting these CTs for anything. If you have a cough, they will, I mean, recommend for a CT. It's not true. So CT is very plenty available, because you don't pay for that. The insurance company pay for you. It's not like our system. We have to pay like 30,000, 25,000 to go for a CT. But because of that, it's very limited. But if the insurance company is willing to pay, why not to go for a CT? I mean, there's a lot. So what they say is, if you go with the current practice, I mean, the way you take in these CTs associated with the the CTs, there will be 5% of new cancers annually, the detected, whatever the cancers total. What that meaning is, let's say in 2026, there are 100 cancer patients you identify. Out of that 100, 5 is from because of the radiation from the CT. So annually, 5%. That's what the prediction is. It's not me. I mean, it's the paper says, and it was quoted various places, and so about 5% of all the cancers in US. So it's in US, could be attributed to the CT scan radiation if current usage is continued, yearly. And there's another article very recently came last year by September. This is about the pediatric and adolescents, which mean 15 to 21. So they have done about 3.7 million patients. They worked on this. This published in New England Journal of Medicine, again, one of the top journals. What the study says is exposure at the early stage, there is a significant factor to increase the probability for cancer at the later stages. So these people have followed the patients from 1996 to 21 years up to 2017, followed each and every these patients and came up with this. And it was stirred the entire radiology kind of studies. And there was a news article came like saying study assess the cancer in children exposed to medical imaging, where 4 million children were studied, and they found, 10% of pediatric blood cancers are because of the radiation exposure. And this one, I think this is the last. This came in 2015 from the European Journal of Radiology, one of the famous one. This study is from India. It says clinical application of justification and optimization principle of ALARA in pediatric CT imaging. How many children can be protected from unnecessary radiation? So what the story is, there were about 1,302 patients who were referred to a CT image. Image is like health center where we have the CT machine. There's about 1,302 CT. The patients were referred to the CT, and there were multiple organs or maybe anatomical area they're supposed to. So it's about 1,392 images of CT from these 1,302 patients. When they went through all these requests for the CT by the experts, by using these justification and optimization kind of a procedure, and they found 105 pediatric patients no need to go through the CT. So they can either go with an ultrasound to find what the problem is, or maybe MRI to find what the problem is, and but they saved, unless the exposure of these 105 kids, going through the CT. So now there are a lot of studies and the results are coming out. So we have to be extremely careful, especially the pediatrics, when they exposed to radiation. There's a wonderful book from the WHO, Communicating the Radiation Risk in Pediatric Imaging. If you have a time, have a look on this. The key part I want to point from one of the tables in that book is these highlighted two things. If you take a chest CT or abdomen CT for an adult, that is equivalent to 350 normal projection X-rays. Which means the whole year, 365 days, you can take the images that is equivalent to one CT that you're taking on the chest. This is not me. These are all. Went up to 400. Now it has, come down to somewhere 350. So exposing to CT image is not that easy, or not that recommendable. But provided that, CT is the only option to kind of diagnose what the problem is. There is no other options. Like head injuries, very commonly, you have to do a head CT. There is no other way the doctor can find where the internal bleeding or whatever the hemorrhage or whatever the issue is. So there are instances where it is a must, and there's no way they can compromise. But in a pediatric case, especially, if somebody suggests something, you better get a second opinion and see whether it is a must to go through the ionizing one or the CT. Can I do this with the MRI, or maybe can I do this with the ultrasound, which is not ionizing radiations anyway? Okay, what are the messages I would like to kind of want you to take home, and the benefit versus risk. So I'm not here to kind of go against or maybe talk about the X-rays and CTs are bad. No, it is all depend whatever the benefit from this imaging versus whatever the risk. If it's a life-saving one, of course we have to go for that. And radiation exposure, especially, for the kids and the modalities like CT and repeating the same thing again, going for a one. Let me give you one example of the repeating exposure. My son got actually, he wanted to get a form signed by a medical practitioner by looking at his chest x-ray to say he don't have any bronchi problem and all. He was going to US. Then about 2 months, I think, he got a X-ray from the our medical institution, medical lab in the AHS. That was the university admission here, so he got one seat. I mean, the chest X-ray. So this came for the scholarship. So I asked him to go and meet one of the private hospitals here, and tell them you have your X-rays, and ask him to kind of fill and sign that form. So the OPD doctor there in the private hospital said, no, we can't because we have to take we have to take our own X-ray for us to give some whatever the comment. Then he called me while he was there. Then I said, okay, you stay there. I'll come and talk to him. And then I went there and I told him he exposed about 2 months ago. I mean, the same thing. Do you want him to expose again? Do you think that is safe? Then after few talk, I mean, there's not argument basically. Then he said, no, I'll take this to the radiology unit and I'll check with them and then I can recommend. Then it came that way. Since I know the exposures and repeating one thing, I mean, twice is not necessary, I managed to kind of, you know, not to go for another X-ray. It's not the money. It's again, I mean, exposing to radiation. So the message is that, I mean, if you know exactly what's going on and if you can talk to people, I mean, not to fight, but just to explain, I'm sure you can avoid unnecessary exposures. So not all imaging are ionizing. So the ultrasound and MRI are safe. There's no ionizing radiations. And you have to give the special consideration for kids as well as the pregnant women. Sometimes people don't know they are pregnant. They go for these images. And you have to always check, I mean, whether there is a possibility and you don't want to go for an X-ray or can I settle with the MRI. And there are responsibilities for us as patients and to kind of inform the doctors because they don't know anything about us. And we have to say the previous images and all to get something, less exposed. The other serious thing is the rate of exposures, the rate of tests, rate of X-ray related ones are increasing. This is the data from 1980 to 2005. It's about 25 years. We are now 25 years past from there. It is not alarming, but if you look at the green, the blue color light is the background radiation in some countries. So we are somewhere close, but it is not something alarming. But the rate is increasing. So I don't know, by now we may be in the 5 millisievert per year. Even if it is 5 or 6 millisievert per year, that is fine. I mean, for a radiographer or maybe a radiologist or people who are working in the radiation facilities, they have a limit of 20. Yeah. So 20 millisievert per year for a radiation occupationist who is working in the radiation facility. So he has a 20 per year limit is there. So we are not even close to that. So we are 100% safe. So, but these are the factors we have to take in. There are organizations, this is my last slide, which is like image gently and image wisely. These are organizations to kind of promote these ideas of use whatever non-ionizing or maybe go for a low dose, which comes with the poster, one size does not fit for all. And we have seen that they choose the same size for all in our systems. There was one student worked in the Lady Richway, I don't want to name the hospital, but um, the CT was broken and the patients were taken to National Hospital and they used the adult protocol for all the pediatric. So imagine the size and this thing. I have data, but I didn't publish, and I want to create more enemies in the field. And we can talk and discuss and settle things. So one size never fit for all. You should know the size and what is needed, and all there in the poster. There's no question CT help us to save the kids' lives, but radiation matters. Always more is not what we look for. If you get more, it's always better, but not in the radiation. So you scan whatever the area you have to, because scan length is extremely important in the CT. If the CT is only for the head, don't go to the neck because you have the thyroid there. So scan length supposed to be only in the head. So there are various things. The person I talked to you again, I mean the operator is the key. I mean, and what the doctor needs in most of the cases, all matters. So that's the message. And thank you very much for listening this long time. It's almost 50 minutes, and I hope I didn't take more time. All right. Thank you very much.
Professor Sivakumar, thank you for very insightful presentation.
Thanks.
Would like to now we have the questions and answer
Yeah.
sessions. Please feel free to ask questions. I will start asking a question. Now there is this CT angiogram.
Yeah.
Uh, Now, actually, the first time I heard it was when I was with a doctor who is not a physician but in some other specialty.
Okay.
And so the risk is the same, is it?
Yeah, I mean, I'm not that much because there are latest techniques. I mean, every year you get something new, and even when I hear the CT, which is about 640 slices, so we go through one slice by one slice. What they have in a new one, a private hospital, new one is 640. I went crazy because in one round you can cover about 16 centimeters, and you hold the breath, and the CT is done. Earlier, I mean, long ago, I mean, it was like half an hour procedure, and so the technology is improving a lot. So to be comment on that, I don't have much about the angio with the CT, but obviously, I mean, CT means you go in the tomography, means you go the slice by slice. So every slice you need the radiation, and you want to see in every millimeter, maybe, I mean, what the situation is in terms of that. Whatever the angiogram mainly come for these the blood circulations or maybe the vessels, so they may be looking at that in that resolution, maybe. Yeah, obviously, yes.
Okay.
Yeah.
Thank you.
Yeah, any other questions?
Sir,
Yeah.
I was like two questions. Uh, the first one is like when we single out the cancer cells and like do radiation therapy on it. So how do we like uh, direct the radiation only to that cell, or
Yeah.
is it like more damaging towards the surrounding cells?
Yeah, can I answer that?
Yes.
Okay. um, Therapy, I mean, there are various ways you can do it. I mean, teletherapy or maybe external beam therapy means your radiation source is outside the body. It's like you have a source, maybe a Kobo 60 or maybe a LINAC, linear accelerator, where you get the X-rays, high energy X-rays. If you move it around the body by focusing that particular point, you get more radiation than other places. You can reduce the exposure to other cells. Do you understand what I'm talking about? So you have an object, and you are kind of imparting the radiation around that, but there is a point. At that point, the entire radiation, whichever the direction is, passes through. But the other ones maybe once or maybe twice, but this one you get more. That is one way in the external beam therapy. In the brachytherapy, if the cancer cells are close to a cavity where you can have the access to that, close to that, then you can send these or you can place these radioisotopes very close and let them to irradiate, like cervical cancers, colon cancers. They keep these in a insulating kind of a radiation blocking system, and they insert it to the cavity so that it can irradiate. So you can closely kind of do that. That is one. There's another one where it goes to commonly to all, but it will be considered later on, like the iodine 131 therapy. The experts are there in the back. You give the iodine 131 in an oral as a capsule, and then there the iodine is labeled with 131, not the normal iodine, which can decay to, I think, xenon, and then it can go down to ground state by emitting a gamma in about 360 keV photons. So when you take that, the iodines are normally concentrates in the thyroid gland. If somebody is having a thyroid cancer, then that goes and stays and irradiate with the gamma. It can kill the cancer cells. So the key, I mean, the challenge always in radiation therapies, can we preserve the good cells and kill only the cancer cells? Very hard. But there are therapies coming, like, for example, the proton therapy, which is a particle therapy. Whatever we are talking about is the photons, right? X-rays and gammas. But if you use particle therapies, you can calculate the where the the protons goes and stop and give all the energy at once in that particular place. So the proton therapy is becoming popular, but you can't do it for all the therapies. I was remember when Professor BSc was here, he was talking about that, and we consulted the Apollo in India and all. Certain cancers you can't. I mean, like the modalities. I mean, X-ray cannot be used for all. Like ultrasound cannot be used for all. Like certain therapies work for certain cancers and not all. But your question is whether we can save the good cells and kill the bad cells. Not 100%. It's not that easy. What was the second one?
So the second question is is the number of X-rays, like the the amount of radiation that we are getting, like the sum of the radiations, is a thing that affecting our health, or is it like the rate, like the amount of radiation that we are getting within a certain time that is more like damaging to us? Like,
yeah, as I showed that Alara principle, I mean, there are three things. I mean, the time that you spend or exposed to a radiation is bad. I mean, more means you get more radiation. The other one is the distance where you are close to the if you are close to the, because the radiation intensity decreases in 1 over r squared form. It's an inverse decrease in the intensity. So if you move 2 meters means you're trying to, 1/4 of whatever you had it at that point. So distance and time and the shields or whatever, they can protect. But in terms of radiation, the problem is with the energy of the photons, and obviously the intensity also there. If there are 2 photons coming with one energy, or maybe 100 I'm getting, I mean, then I will be hit by hundreds. Energy, because the interactions depends on energy. It's like a family, because in your normal X-rays, I mean, the projection type X-rays, you get a spectrum rather than a unique 1 photon energy. If the radiographer sets for the, let's say for a fracture in a hand, let's say he set for a 60 kVp value and some milliampere in the tube current. If you set the 60 means the maximum photon you're getting is the 60 keV photon. That's the maximum. But most of the photons will have about less than half, maybe around 25 keV photons will be the majority. But you'll have less than 25, more than 25, up to 60, you'll have photons. So all these photons won't do the same damage or maybe interaction with the medium. High energy photons, they have their interactions, and when you go high and high, the scattering will be more. If you're in 20, 30 keVs, the photoelectric absorption is more. So it's like, I mean, the interaction is like a family visiting another family. Like, I mean, yeah, I will talk to the main man about my job, but I don't go and play with the small kids. But the small kids have their life and they have their own interactions, right? So the spectrum is something like that. I mean, you have a very high energy photons there to do their own interactions, and there will be low energy, they have their interactions and so on. Yeah. So I don't know, but the question is, but am I answered whatever the doubt you have, or
yeah, quite a bit. So, what I like actually asked was like the rate, as if like the number of X-rays that we are getting per year, like that.
yeah,
So,
it's like accumulated. Yeah, it's a cumulative one, of course. That's what we go with the 20 millisievert per year per radiation worker. That is for the year. So it cannot exceed up to 50. Am I correct, Malik? Yeah. It's up to 50 is the maximum per year. He can't go for more than 50. Let's say in a 2-year time, he covered almost like 60 or 70. He has to be sent compulsory leave to cover that entire time frame. I mean, for how many years he's supposed to. So that's the ICRP and IAEA regulations. I mean, you can't, I mean, they have their own dosimeters. I mean, Malik is there. He's one of the radiation worker here. You have a badge you wear all the time, and you look, I mean, it's a TLD badges. You send that to the atomic energy in Colombo and measure every year how much the exposure is. So it's a cumulative one. So if you exceed per year limit, then you have to go for compulsory leave until you cover the rest, and then you come back again. Yeah, it's must. And we are under the IAEA, and we have to follow all the regulations, what they say. So the radiation, yeah, I mean, today I exposed like it's okay. Another 2 months, I can go and expose. No, it's not like that. It's a cumulative one.
Thanks.
Yeah. Any other questions?
So I have this question.
Yeah.
I don't think it's a good question, but I had to ask you because you cover not just medical radiation, but the high energy research level radiation as well. So you mentioned that we have hospitals with active radiative sources, and on the road also we might encounter these radiation sources that are being transported back and forth to hospitals, medical facilities. And we have at least three ongoing wars around the world, and maybe unintentionally people attack hospitals as well. So how dangerous these kind of attacks, these kind of accidents happen in and around hospitals to the general public, and do we have any like regulations or protocols newly established to mitigate these kind of unintentional catastrophes?
Okay, that's a really good question. Now, those kind of accidents and issues, transporting and storing and keeping, is mainly comes in the nuclear medicine area, not much in X-ray based ones. We had these cobalt 60 sources in Candy. We had, well known as teletherapy machines and all. We had these radioactive sources. But in the nuclear medicine, not much now in the nuclear medicine unit here. But those days we used to get the iodine 131 every Tuesdays. Every Tuesdays. So when they transport from the airport, and there will be an ambulance and there will be guards, and it will be transported in a very professional manner. Once that come to the nuclear medicine unit here in medical faculty, it will be stored in these lead covers, so it's very limited access to people. And yeah, I mean, this Sri Lanka anyway. We had issues, and we had issues with lead blocks because lead is very expensive, and we lost some. There were some inquiries and all kind of stuff. But within the activity and whatever we use, I think it's safe because 30 millicurie is what they give for these outpatient thyroid cancer patients in nuclear medicine, and they will let them go home. If the activity is more than 30, it goes to 100 millicurie or 200, then they have to be kept in inside patients. So facilities, what we have in Badulla, Kandy, and Kurnagal also, we have Maharagama, of course, and Jaffna. They use very high dose, high activity iodine 131. They have these isolation wards where the iodine 131 is given and keep the patient in a separate ward. Nobody can visit the visitors until the half life. It's about 6 hours, I suppose, right? 6 days, yeah. So maybe at least about 3-4 days they have to be kept isolated for the iodine 131 treatment. So far, the problem is, as I said, I mean, if there is a radiation, let's say there's somebody's carrying a iodine 131 in the pocket, and who knows what is there? Because we can't sense a radiation, not like a heat that I can sense. I mean, when some radioactive sample is here. So that is the danger of the radioactive samples, and when it get to a bad person, I mean, what we see in these wars and all, it can end up in a disaster, of course. But at the moment, because the knowledge is not that much, kind of, somebody to kind of use it. Maybe other side also, I mean, because without knowing, people can steal things, and because of the social setups and all, or the economy and all. We don't have such the atomic energy has some protocols for the safety and all. Every year they make a visit, like to our neutron lab. Every year they visit, and they have to give a certificate, and they will check all the background radiations and stray radiations and all, and they give a certificate. We have to pay for that. Other than that, yeah. And they get technetium 99 as well for the nuclear medicine, right? Yeah. And some of them are not that kind of energetic gammas comes out, but yeah. So it should be. I mean, nuclear medicine is a problem. Not all the hospitals have the nuclear medicine units. Some they have. In the Kandy we have, and Kandy recently started the inpatient iodine 131. Badul, there's one, and all our medical physicists are there. yeah, the nuclear medicine one is a bit worrisome. And the teletherapy machines, the Cobalt one, are now replaced by Linacs. Linac is a basically the X-ray machine, but we accelerate using a Linac and get the high energy of 1 mega electron volt or more. So that you can turn it on and off, and it's not like the radioactive cobalt. Now, cobalt, once you bring in, it's we keep on irradiating, whether it is working hours, whether it's raining or whether the power is there or not, it will be keep on radiating, and that's the problem with the isotopes. But the Linux, I mean, it's like a normal machine, and now we have more. I mean, Candy, they have two. So there are two Linux in the Candy hospital, so it's safe.
Thank you, sir.
Yep.
I have a question. You said like the brain is now considered as less sensitive to X-ray. So I had the question. So we have the skull, and once the X-rays, let's say X-rays go through the skull, they will get attenuated.
Mhm.
So inside the brain will be something. Inside the skull will be something smooth.
Yeah.
So don't we need more radiation because like the skull can act as a shield?
You mean for the imaging process
Yeah.
or for the sensitivity?
Imaging process. I thought once you
Yeah,
get
we have a separate protocol for head CTs and skull images. So they have a separate protocol in the sense the operator who's supposed to operate, let's say a patient comes in with the head injury, and let's say you want to go for a head CT, and whatever the KVPs and scan, whatever the parameters that he set, is different for whatever the previously or after somebody's coming with some other abdomen scans. They won't the same size won't fit in there as well, because not every anatomical region is scanned in the same protocol.
Okay, so I was wondering then the brain will also become more sensitive.
No, the sensitivity is totally different. It's a biological kind of measure to see. I mean, because whether you can recover it. Now, when you expose to a radiation, there are three things can happen. One is a death of a cell. That's high dose, which very rarely happen. Maybe in an accident in the Chernobyl or maybe in the Fukushima, where you have very high dose and you kill the cell. The second option is, you damage, but the cell can repair it on its own and get back to the normal job. So it is completely recovered and it's doing the same job, like let's say whatever the cell in the liver or maybe in the cardiac, whatever it is, or brain. The third is the dangerous one, where you make the damage and the damage persists, and you prepare and produce more and more bad cells.
Like cancer.
That's what the cancer is. So that's where so if it can recover and repair and get back to the normal one because of the type of the cell what it is, then it is less sensitive.
A sensitivity in
So
that
it's
sense.
purely a biophysics and what do you call radiation biology part, where you classify them, because these are all, I mean, as I said, I saw 3 tables now so far. Who knows, this 2007, maybe 2026 we get another table. Not a big change, but there may be move here and there, but overall this is what they are measure about the sensitivity of different organs. Yeah.
Thanks.
Sir, good evening, sir.
Yeah, good
I
evening.
have a question, sir, actually. So it's about this radiation safety awareness and the stuff mainly. So basically, like students and like some people got the privilege to get to know about the awareness about radiation safeties and measure. But when it's come to general public, like there's still a knowledge gap about this awareness. So as you can see, even before from my personal experience, so before coming to the university, I remember that my mother got 2 X-rays within some short amount of time, like as a hospital recommended. So during that time, I never had the idea like this might host the biological effects there, and there might be the harmful thing due to this one. So how like this, there might be more people and public that might not have the proper awareness about it. So is there any ways and measures that we can like to take to make this public like aware about these safeties and measures?
Yeah, one of the possibilities, I mean, having some part in the syllabus of teaching about, let's say, medical physics. In the London syllabus, they have medical physics as one of the content in the physics courses. So there talk about the radiation effects, and different modalities and so on. So there you can incorporate one. The other one is, it's an ethic that the person's supposed to follow. So we have visited. I had 3 MPhil students, one completed. We were visited many hospitals to kind of measure these reference levels for different things. Even we went to Jaffna, and the way we looked at the way they practice in certain hospitals, which is not ethical. So when a profession becomes a job, or when a profession becomes a business, including education, you lose the ethics. See, the word profession means I'm dedicated to this. I want to educate. It doesn't matter if there is a mid exam, I have to how much time I input and how much time I will correct, and I'll talk to the students, the feedback. It's about my ethics. So, which I see in the health sector, it's more. I don't know, people will get offended sometimes, but nothing to all due respect to everybody in the health sector. We need more professionalism and ethics to kind of safeguard, because teaching or the education in the country has become student centered almost now, but not the patient centered healthcare. People will see. I was in this field. Working in various hospitals with the people, and I don't want to get into kind of a fight, but we need that. Otherwise, your problem. Your question is very genuine, because people say he went to our people in Single. They say current allandagiya, or in Tamil current pidikka poitar. They don't know what that is. Is it a current? I don't know whether it's the same in Sinhala. People say, in Tamil they say, yeah, to other current alland. What is that? So we need from the bottom to educate people. Otherwise, this is what it is. In other countries, they have all kind of leaflets to give when somebody is going to do a procedure. So they give you a date to come for a CT, and they give you a leaflet to read that and prepare for your scanning. There they have all the details in whatever language you are comfortable with. So for that to get to that level, I don't know when, but that's one way. Other one is you have it in the general, what you call education school level, to kind of educate people. Radiation, it's not to scare people. That's what I was worried about this talk, because people should not label me, I'm against the radiation images. No, it's not like that. We have the responsibility as a patient, as the radiology professionals, radiographers to radiologists to all, use this. In some hospitals, there was somebody taking maybe a old person to go to the medical imaging. Sometimes the guy is in a hurry to go out, and people are doing all the private practices. He just pulled the guy who came to help the person to take the image. So I don't want to go into more, then I'll be end up in trouble even more. So we need more in the ethical side, and I think that is what lacking in the government sectors. Plus the large number of patients. If you go to just a clinic and see how people struggle, they have to go by 5 o'clock, sometimes 4 o'clock, to stay in the line, and they will get a number by 8:39, and the doctor will see them by 11 o'clock. Even not the doctor they want, some trainee, somebody, and they prescribe the same kind of a medicine. They come out. It is right or wrong, I don't know anything about, because I'm not in the profession. But if you look at the way things are happening, I think we should have more ethics guide us to the profession. That's what I would say, including the education. The profession is something. Job is something. Job means I am done. I close 4 o'clock. I'm done. I'm gone. I don't damn care about what's happening to the system or to the patient or anything. But in the medicine, it cannot be a job. It has to be a profession. There, the ethics is better.
Thank you, sir, for your insight.
Are there any other questions?
Doctor,
Yeah.
Doctor, I know a person, he faced an accident during 2024, and he had to take a CT scan and about 3 X-rays in his body, and CT took on his brain.
Brain.
And,
CT.
yeah.
Head CT. Okay.
After about 2 years, another incident happened, and he had to took another CT scan on his brain and took another X-ray. My question is there a healthy timeline between those scans?
Healthy?
When we take scans, is there a healthy timeline?
No, I mean, see, this is about the problem. If the accident happens, how can you wait and ask the patient to stay for another 3 months to go for a CT? No, you can't. It's always what you measure at that time, what is needed for. So if you want to save the life and make him comfortable after that accident, then definitely you have to go for a CT. There's no any other option. You can't now, same as for a kid, I mean, had a fall, I mean, some you suspect in the head injury or something, there's no option at all. You can't go and talk to them saying that, yeah, we heard in the lecture that radiation is bad. No, it is not about that. It's about saving the life. And the doctor can't see inside. The only way is going through the images. And you can't wait for a timeline there. No.
So then, if there a person who took so many scans like that previous incident, is there a procedure to check whether he's in a danger or some kind of risk?
Yeah, I mean, if you look at these papers which I quoted, I mean, they followed the person from, I don't know, 2006 or 9 to 2017, the patients. So they would have done the same thing. Like if your friend is one of the patients, they would have did all kind of tests. I mean, anything, cancerous based, or I don't know what those tests are, and they would have done that. So I don't know. I mean, because it's not my profession to answer. I mean, whether what he's supposed to do or what he could have done or sort of. But I think it's not a big issue at all. I mean, going for a few CTs. At the I don't know what the age is, but if he is not a age below 21,
He's about 22 years old.
yeah, so he's in the adolescent and above. He's an adult almost, and I don't think it's a big deal. But I don't know. I mean, I don't want to scare anything saying that go and see a doctor or something. But I don't see personally from my whatever the articles that I was reading and looking at. I don't see there will be a big issue. But the problem is this. I mean, if you go to different doctors and so you change the consultants and go away. I mean, go around less bad about Sri Lanka because I can take a medicine today here. I can go to Colombo there and various places. If you don't have a proper history of what images were done so far, then if you go and talk to a doctor today, he will say, let's take an MRI or a CT today. So unless you commit and say, yeah, I have done this many CTs in the past, is it a must to go for now? Or can we settle this with an MRI or something? That, of course, you can, rather than saying blindly no or yes. I mean, that's what I said. The patient's responsibility is also there to kind of inform the doctor because he don't know anything about you unless we have these digital patient histories stored in somewhere. Then people know that. Or if you are following the same doctor, I mean, from the beginning, then he knows and you can tell him. Unless that, I mean, if you just go and ask the doctor, he will say, we have to see your CT now. So I mean, second opinion thing is like, I mean, you go and ask. I mean, I have done this many CTs, and why we have to do it again, or is it something must? If it is a must, then there's no option. I mean, we have to do that. Yeah.
Problem is, as that says it, people don't aware about
Yeah,
these
yeah, yeah.
details.
Sure. 100%. Yeah.
So accidentally, someone can possibly face that incident.
Yeah.
So
No, I have seen many in my experience. There are repeated X-rays, repeated CTs, and all, which sometimes I think it's not necessary. But as individuals, we can't do that. I mean, that's what we need. I mean, awareness. I mean, to talk to people. But I was a bit nervous because it should not projected like, I mean, yeah, going to CT is bad or something. No, that's not the point. You should know, I mean, when to take and when to avoid and when to kind of go for the other option or less dose. And we should be able to, I mean, judge. And obviously, we should have some knowledge on that. I mean, to start with, yes.
thank you, Doctor.
I think we had a very insightful discussion over the last 1.5 hours.
Yeah.
Now, finally, I think it comes down to professionalism because when we take medicinal drugs, he said there are some side effects. So that is why there are certain over-the-counter drugs and other drugs you cannot take like that. So it goes the same into this. And we are so thankful to Professor Sivakumar for enlightening us on this. Actually, the Human Resource Development Unit always share these uh, insights through the YouTube channel. So we will feed that also into that. And once again, we are so thankful to you for accepting our invitation and enlightening us on this very timely topic. Thank you very much.
Yeah, thank you very much and having me on this. Thanks.